Hello, welcome to the No Specific Molecular Profiles Support Group at Share Uterine Cancer. And we are very excited today because we have a speaker, Dr. Stephanie Gaillard from Johns Hopkins, who's done a lot of research in this area. So before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face um, uh, breast, ovarian, uterine, cervical, or metastatic breast cancer alone, or metastatic uterine cancer alone. Please, for more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. We kindly request that all participants mute themselves during the presentation. Once Dr. Gaillard finishes presenting, we will begin the Q&A discussion. Feel free to ask any questions through the chat section at the bottom of your screen, or come off mute and ask her directly. Remember that Dr. Gaillard is unable to provide specific medical advice, so please keep your questions general in nature. This presentation is being recorded, but not the question and answers, and will be available on the SHARE website soon. Okay, and after the questions and answers finish, we will, when Dr. Gaillard hops off, we encourage anybody who would like to participate in further discussion or the support group to stay on. Dr. Gaillard?
All right, super. May I go ahead and share my screen?
Yes,
all
please.
right, fabulous. All right, are you seeing my screen? Okay, fantastic. So really, it's a great honor to be asked to talk to you all. This is an area I'm very, very interested in, and I'll talk a little bit more about why later on. But I'm Stephanie Gaillard. I'm a medical oncologist. I focus on women with GYN cancers. And I came to this not necessarily in a straightforward manner. So as a medical oncologist, many of us actually don't see a lot of patients with GYN cancers. My background is in cancer biology. And as a cancer biologist, I was studying hormone nuclear receptors and became very interested in the role of these hormone nuclear receptors in GYN cancers. And so this is an area near and dear to my heart. So today I'm going to be talking about these NSMP, as they're called, endometrial cancers. That stands for no specific molecular profile. I'm going to talk about what they are and what we're learning about what some of the treatment options are available. So I'm, as I said, a medical oncologist. I'm at Johns Hopkins. I lead the Gynecologic Cancer Trials program here, and I'm also co-director of the Developmental Therapeutics program for the Cancer Center. What I want to do today is provide some background on the rising incidence of endometrial cancer, because it's something that we're not really talking enough about, but is really quite startling. I then want to jump in more into the NSMP subtype. I want to review recommendations for the type of molecular testing that should be done for all patients with endometrial cancer. And then present some of the clinical trial data specific for NSMP where that's available. Keep in mind that this is not at all a comprehensive review of all the data that's out there. There's little bits and pieces coming from various different studies, and we're really starting to kind of focus more on this group. And so I'm hoping that we'll get a lot more information in the coming years. What I'm presenting today is purely educational. They're not personal treatment recommendations. And this field is constantly evolving. And so what I present today may be outdated soon as new data emerges. I want to just mention some of my disclosures. I do have a number of research grants. Those are paid to the institution. I have worked on advisory boards and for consulting. And I do have a patent for the use of lasofoxamine for breast cancer, which is licensed by Duke University to Sermonix. None of these things are directly related to endometrial cancer or NSMP. I will be talking about some drugs today that are in clinical trials and therefore not FDA approved. And so just be aware of that. All right, so one of the things that has been really heartening to see has been a dramatic improvement in cancer treatments over the last 25 years or so. I entered medical school shortly before Y2K and didn't really realize all the progress that we were about to embark on, but it has really been a dramatic improvement in treatment options, in outcomes. You can see in detection and a decreased incidence. And so it's been really, truly phenomenal and exciting to be in this field. Unfortunately, this hasn't really translated in endometrial cancer. And in fact, it's one of the few cancers in which there's a rising incidence. Back in 2022, there was about 66,000 cases, and they were in this study, they were projecting 122,000 cases of uterine cancer in 2030, which is really just around the corner. So it's really, these are quite astonishing numbers. And you can see that there's a 1.8% annual increase in uterine cancer mortality in the United States from 2010 to 2017. This is a phenomenon that's going on around the world. It's back in 2013, they were mentioning the increased in endometrial cancer diagnoses around the world. And worldwide, there are 97,000 deaths due to uterine cancer in 2020 and 417,000 new cases. As I mentioned, this is going on around the world, and here's a map of all the countries in kind of the orange and red and the deep maroon, or where they're seeing the largest increases in endometrial cancer, and you'll notice United States is among them. And unfortunately, we're having worsening outcomes in certain populations in the United States, with Black women in the US faring worse and are 2 times more likely to die of this disease. And unfortunately, we're losing ground. So the mortality rate is increasing in Black women in the United States. And when I first started as a faculty member back in 2012, we used to talk about ovarian cancer as being the worst of the GYN cancers. And unfortunately, the mortality rate of endometrial cancer now is equivalent to ovarian cancer, and we expect to surpass ovarian cancer. Fortunately, there's been a dramatic improvement in our understanding of the cancer biology of uterine cancers. This is really an age of molecular classification. We started out, here's some histology slides. So what we knew about endometrial cancers came from looking at them under the microscope and looking at the various different profiles. And we knew that there were different subtypes of endometrial cancer, but we really treated them all the same. And so knowing those subtypes didn't really change anything. But what we've learned is that there are these hallmarks of cancer and all of these different mechanisms that can go awry as a cancer evolves, develops, and then evolves. And we now know how to look for a lot of these various different things. And so here's a study that looked at various different molecular profiles of endometrial cancers. in a number of different ways. So looking at different mutations in genes, looking at the chromosomes and what we call copy number alterations, and just did a whole profile of several hundred endometrials to get a better understanding of what they look like. And what they found was that you could classify them into 4 main categories. The first one, pol E, or pol epsilon, is these tumors all carry an alteration in the polymerase epsilon gene. And what it leads to is just hundreds and hundreds of mutations per megabase. And that lends them to be actually much more sensitive to immunotherapy. And even a patient's own immune system tends to go after these, and so they tend to have better prognosis. Then there's the MSI high or MMR deficient endometrial cancers. MSI high is for high microsatellite instability, or MMR deficient reflects an alteration in the mismatch repair pathway. And this causes dozens of mutations in the per megabyte. So a little different than pol E, but similarly does predispose these tumors and patients who have them to respond better to immunotherapy. Third category is what we call the copy number high. What we see there is rather than individual mutations within a gene, so a mutation you might think of as a misspelling within a gene, but these are widespread chromosomal abnormalities. So if you think about, again, using the analogy of words, chromosomes would be more like paragraphs, and these chromosomal abnormalities might be duplications of paragraphs or taking a section of a paragraph and moving it and putting it in front of a different section, which completely changes the story. And so similarly, in these copy number high tumors, you might find all kinds of different changes, but not as many misspellings or mutations specifically. And then the fourth group is what we call copy number low, or the no specific molecular profile group. And it's called that because they were the leftover tumors that had no specific molecular profile. So they were all lumped together in this one category. And what we know, what I started out by saying, is that we used to just look at these tumors under the microscope and determine their histology. And we knew that there was an endometrioid type, a clear cell type, a serous type. And what we found is that when we look at them by molecular subtype, that they're really quite heterogeneous in terms of the various different kinds, the various different molecular subtypes that are there. So the classification. So as you can see in the upper left corner, the low-grade endometrioid cancer predominantly fall in this no specific molecular profile group, but there's also some that are in the MMR deficient group, some of them who are pol E, and some of them that carry these P53 abnormalities or are copy number high. And so that kind of heterogeneity is apparent throughout, except for these serous carcinomas, which tend to be in that copy number high or P53 altered group. What we do know is that these 4 different classifications really tend to reflect outcomes in the different groups. We know that the incidence of pol E is pretty low, and the mortality is also very low. I told you that these tend to be very responsive to treatment and have good outcomes. These MMR deficient tumors account for nearly 40%, and the mortality is relatively low as well. The NSMP group accounts for about 50% of endometrial cancers, but the mortality tends to be relatively low, thankfully. The copy number high accounts for a really small percentage, but unfortunately the mortality of those is quite a bit higher. And so that's what we'll focus on today is this NSMP group. So given the information that we learned from this study, which is called the TCGA for the Cancer Genome Atlas research network that did the study, is that really we need to do this molecular profile very early on as patients are being diagnosed, because it's prognostic. It can tell us a lot about what we can expect. And also in some situations is predictive, as I mentioned, with some of the tumors being more responsive to immunotherapy as a result of their molecular profile. So for example, and there's been a lot of different groups who have put together different recommendations, but this is from the NCCN, the National Comprehensive Cancer Network, and they present their recommended strategy for doing tumor molecular analysis. They recommend starting with POL-E, and then if, because that separates the POL-E group, and if not POL-E, then checking for the MMR or MSI high. If it's not those, then looking for P53 alterations, which would allow us to differentiate between the copy number high group and the NSMP group. They also recommend some other testing: HER2, estrogen and progesterone receptor, the NTRK gene fusions, and tumor molecular burden, depending on certain circumstances. Now, in truth, we don't necessarily go through this in an algorithmic sort of way. We often just get all the testing done all at once. And there are lots of different panels that are used, companies that do them, different institutions who will do the testing internally. And so sometimes we don't necessarily start with POL-E, but we may start with some of the other ones and kind of go from there. But what do we know about this NSMP tumor? So as I said, they account for about 50% of all endometrial cancers, but not all NSMPs are the same. It really is a mix of these low-grade endometrioid, high-grade endometrioid, these clear cell type, and another type I haven't mentioned yet because they are kind of newer, but the mesonephric-like. What we can say about them is that they don't carry mutations in P53. TP53 is the gene name, P53 is the protein name. And so we say that these have wild type P53 expression or normal expression. There is variable expression of estrogen receptor. We'll talk a little bit more about that in a little bit. And that there do tend to be some common pathway alterations, some in beta-catenin, which can lead to activation of beta-catenin and has been shown to be carry a little bit more aggressiveness. PTEN mutations leading to loss of PTEN expression, and then PIK3CA mutation, which can lead to an overactivity of the PIK3CA gene. What you can see is many of these same genes are mutated in other groups, such as the MSI high group or the copy number high group. So they are not limited to the NSMPs, but are commonly altered within these groups. All right, so first question was, does molecular subtype influence response to therapy? Well, I've already alluded that it does. But first, I want to talk about some of the older clinical trials and sort of the ones that establish chemotherapy for the treatment of uterine cancers. So GOG 209 was a study that enrolled patients from 2003 to 2009, so before the TCGA, and it was a study that really established paclitaxel and carboplatin as the preferred chemotherapy for advanced recurrent endometrial cancer. GOG 86P was a phase 2 study, and it enrolled patients from 2009 to 2012, again, also before the TCGA reported its results. And it was testing combinations of targeted and maintenance therapies. This study showed that there was no difference in the time to progression or recurrence in any of the groups, but there did seem to be an improvement in how long people lived, or what we call overall survival, when the drug bevacizumab was added to chemotherapy and then given as a maintenance therapy. So what's important to know about these studies is, one, that they established really our starting point for treatment. And these are the some of the drugs that we think of as being standard for the treatment of newly diagnosed uterine cancer that's advanced or recurrent. And then also that these studies enrolled patients regardless of their molecular profile. So they were not being selected based on their molecular profile. But we do have some subsequent information. As I said, they were performed before the TCGA. So some subsequent information from GOG 86P looked at whether there were p53 alterations. And what they found was the patients that did not have alterations in p53, so had wild type p53, seemed to do the same regardless of whether or not they received bevacizumab. But patients who had a p53 mutation, which is more commonly associated with the copy number high group, that's the p53 abnormal group, seem to have benefit from receiving bevacizumab. So that was kind of a first indication for us that there may be something that is driving it, driving a difference in response to therapy, and that the molecular differences between these tumors are important. So then we started to design studies to include these kinds of molecular analyses into the study. And so this study is called GOG 3055, or is the SIENDO study. It was looking at a particular drug called Selinexor as a maintenance therapy. And again, this study enrolled patients with all types of endometrial cancer, but they had a pre-specified analysis. I should tell you, the prior analysis of the 86P was not pre-specified, and so not really powered to look at that difference. And so actually it was quite surprising that there was such a dramatic difference in that p53 group. But it's really just what we call hypothesis generating. It makes us ask more questions, but is not really definitive. So this study had a pre-specified subgroup analysis based on the p53 mutation status. And so what you can see here on the left-hand side is that when you just take the whole group together, there's a slight difference between those treated with Selinexor and those treated with placebo, but it's not dramatic. As you look on the right-hand side, and now you're looking at patients with the p53 wild type, they tend to do better when they receive Selinexor than when they receive placebo. When you look at all p53 wild type tumors, there's this separation between the curves. But this particular study at the time initially wasn't looking at MMR. And so they went back and did that and found that there was benefit for patients who had this MMR proficiency, so sort of normal MMR, versus the MMR deficient group, where the separation is still there, but perhaps not quite as dramatic. And you can see some of the outcomes in the wild type and the pMMR, so the MMR proficient. There's a dramatic separation in terms of the median time between the start of treatment and when the cancer starts to get worse. So this was, again, some exciting information to say that, gosh, looking at these molecular subtypes is really important, and we need to be thinking about these as we move forward in terms of clinical trial. And so there's an ongoing clinical trial now of Selinexor as a maintenance therapy. This is the larger study specifically looking at patients who have this p53 wild type molecular profile to see if it will be better than placebo and hopefully will become then an option for treatment for these patients. Now, I'm not going to go into all of the background in immunotherapy. You have probably heard about it. I know Dr. Cohen gave a really nice talk to the SHARE group about treatments in general in endometrial cancer and had talked about immunotherapy. So what I'm just going to present here is a little bit of background. This, again, is showing the impact of molecular subtype on the efficacy of immunotherapy. I mentioned that patients with these MMR deficient tumors have a significant improvement with the addition of immunotherapy. In this, in the RUBY study, it was dostarlimab. In the GY018 study, it was pembrolizumab. But it is also beneficial for patients who have MMR proficient. Now, our NSMP group would fall in this MMR proficient group in each of these studies. The RUBY study has gone on to evaluate the efficacy based on the TCGA molecular profiles, even though it wasn't powered to do that analysis. So this is really a sub-analysis to evaluate whether there was a difference in any of the groups. And what you can see is in the POLE group, everyone does very well. This is a very small group. There were only 5 patients. So I don't know that I would say that they should not get immunotherapy. We know that in recurrent disease, immunotherapy can be helpful. But overall, these patients do very well. In the MMR deficient group, we know that there's a significant improvement with the addition of dostarlimab. There was also an improvement in this copy number high or p53 altered group. This is a group that tends not to have a lot of benefit from various therapies, and so this was really nice to see. There was a slight improvement in the NSMP, but really not as dramatic as you see with these other 2 groups. So it has led some to question whether or not we should be using immunotherapy. Now, it's very important to remember that this is a sub-analysis that was not powered to really look at this question. And so to me, this data does not say that we shouldn't use immunotherapy, but we really should look at this more deeply. Okay, so as I mentioned before, not all NSMP tumors are the same. And so now I want to bring this around to the question of estrogen receptor. Because what we've learned recently is that the estrogen receptor status, and by that I mean what is the expression of the estrogen receptor protein? Is it present or not? And how does that influence outcomes? And in this particular study, they looked at all endometrial cancers, but then did further analysis on the NSMP group, which is what I'm presenting here. And they looked at estrogen receptor and progesterone receptors. Those are the 2 receptors that we know influence outcomes as well as treatment options in breast cancer. And we've known that there are a group of patients with endometrial cancers who seem to have these hormonally responsive tumors, but it hasn't really been well studied. And we can talk more later on why that may be. But this was a really nice analysis and showed that patients who have estrogen receptor positive or ER positive disease tend to have lower rates of recurrence than patients who have ER and PR negative disease. They did a further analysis of various different genes that are commonly mutated in endometrial cancer. And you can see that some of them show up in both the ER positive and the ER negative, but still may influence response to endocrine therapies. What you can see is that while the NSMP group was varied in terms of histology, most of that variability actually turns out to be more in that ER negative category. The ER positive category tends to be much more likely endometrioid type and tends to have more low-grade type as well. And I mentioned these other mutations. Okay, so they proposed to refine this molecular testing algorithm by adding in the estrogen receptor testing so that we can subclassify NSMPs into ER positive and ER negative tumors. And what you can see here is that it does influence it reflects prognosis among this group, with the NSMP ER negative group having poorer outcomes than those who are ER positive. Okay, so then that asks the question, what about endocrine therapy or hormonal therapy? I tend to use the term endocrine therapy. And as I mentioned, we've actually known for a long time that there are some patients who tend to benefit from these therapies, but we haven't had really a systematic approach into determining who those patients should be, who we should be giving these therapies to. This is a study which is now been out for several years. It is called GOG 3007. It was led by Dr. Slomovitz, and it was a study of letrozole and everolimus, which is a combination used in the treatment of breast cancer. This particular study was pretty small. It was just a phase 2. There were 37 patients in the letrozole everolimus group, and then 36 patients treated with tamoxifen and medroxyprogesterone acetate, which is a different type of endocrine therapy that I'm not going to focus as much on, but we've also known that combination has been beneficial for some of our patients. The biggest outcome that came from this study, in my opinion, is that you can see the objective response rate. So that's the percentage of patients who had a substantial response of their tumor, meaning it had decreased by at least 30% in the way we measure tumor burden. Was rather high in both groups, but was highest in patients who had never received prior chemotherapy. And so this has led to the question that some of us have had is, should we be using chemotherapy for some of these tumors? And we have not yet had a study really do a head-to-head comparison between endocrine therapy and chemotherapy. I would say chemotherapy and immunotherapy is still the standard of care, but I hope that we'll be able to do one of these studies down the road. And I think now with the further information that we have about ER's status and NSMPs, and hopefully further information that we'll get down the road, we can kind of hone in on a patient population that may be more likely to benefit from this kind of a strategy. We've also been looking at letrozole and CDK4/6 inhibitors, again, another type of therapy that's been borrowed from breast cancer. This just happens to be one of the studies that's been done. It was led by Dr. Constantinopoulos. It was letrozole and abemaciclib. This is what we call a waterfall plot. Patients whose each individual bar is a patient, and it reflects how much of a decrease they had in in their tumor burden by percentage. And if you're past this little dotted line, that would qualify as a partial response. He also did an analysis based on p53 mutations, and what you could see is that those who had no p53 mutation did better than those who had a p53 mutation. It doesn't really tell us that we should be using this therapy preferentially for that group. And some of this variation could just be because we know that the tumors that have p53 mutations tend to be more aggressive and fare worse overall. Then there was a recent study of fulvestrant and abemaciclib that was just published this year. Again, similar looking waterfall plot with improvement in response in quite a few patients. This study did look at the molecular type similar to that TCGA with the copy number low or NSMP, the copy number high in the MSI high group. And if you just look at the patients who stayed on therapy for the longer duration of time in what we call our swimmer's plot, most of those patients had that copy number low. But what they're not reporting here on this chart is their estrogen receptor status. So lots of different caveats. We're getting bits and pieces from different studies, and I hope that we'll be able to coalesce them moving forward. And then finally, I'll talk about one of the studies that I'm currently leading. It is looking at patients who have PIK3CA mutated, ER positive, endometrial cancer. So sort of trying to hone in on that NSMP group that had the ER positive that were predominantly low grade. And here, those who have a PIK3CA mutation, because we're using the drug alpelisib, which has been used in patients with breast cancer who have PIK3CA mutations and has an FDA approval for that patient population. And so this study is ongoing. It's called GOG 3069. It's looking at the combination of alpelisib and fulvestrant. And we're currently enrolling at 15 different sites across the country. And so it's something to consider for the patients who have the specific molecular profile. And then finally, another area that's really near and dear to my heart is estrogen receptor mutations. And this is something that I had done some work on. I had been, as I mentioned, received my PhD in nuclear hormone receptors and estrogen-related receptors. And this work came out of having found an estrogen receptor mutation in one of my patients with GYN cancers. And this happened actually before they were known about in breast cancer. So we started trying to understand what it might mean to have one of these estrogen receptor mutations. And I had analyzed a group of GYN cancers that had gotten Foundation Medicine testing and had seen that the endometrioid subtype tended to have higher amounts. This should say 1% and then 1.5%, 2%, and 2.5%. So I'm sorry that the decimal point fell off on the graph. But you can see that these endometrioid types and these endometrial stromal sarcomas, another subtype that we've known to be hormonally responsive for many years, that these are more likely to carry these ESR1 mutations. And we know these ESR1 mutations confer resistance to endocrine therapy, and they also can arise in the setting of being treated with endocrine therapy, specifically aromatase inhibitors. And so if you look at the endometrioid subtype, this is a study that we're working on the manuscript for now. Patients who were treated with prior aromatase inhibitors had many more, a much higher likelihood of being diagnosed with an estrogen receptor mutation than those who had never received an aromatase inhibitor, although some of them have ESR1 mutations, even though they've not seen an aromatase inhibitor. This just reminds me to tell you that these ESR1 mutations tend to develop in these hotspot locations within the ligand binding domain. And so that's how they confer resistance, is that you no longer need estrogen to turn on the estrogen receptor. Having one of these mutations actually tricks the receptor into thinking that it's been activated by estrogen and leads to all of the downstream effects that we would expect from the estrogen receptor when it's activated. And this then brings up the question about, will the newer drugs that have been developed for ESR1 mutations in breast cancers be beneficial for patients with ESR1 mutations in endometrial cancer? And I hope that we'll be getting more information soon from ongoing clinical trials and those that are coming down the pike. So in summary, the NSMP subgroup includes a heterogeneous group of tumors, and we really need to further refine the molecular subtyping. Clinical trials are absolutely it's important to include these subtype analyses in clinical trials so that we can better understand how the individual therapies work for the various different groups. We are really excited about some of these targeted therapies, such as the Selinexor and endocrine therapies that looked really promising for this group. But I can't emphasize enough that we need greater participation in clinical trials so that we can get answers to these questions more quickly. Clinical trials really are the key to making progress against cancer. And unfortunately, only about 5% of women with a gynecologic cancer participate in clinical trials. And we can really move the science forward a lot quicker if we can enroll more patients to studies. And with that, I'll stop.